Well, good evening and welcome to this Wolper Wellbeing webinar hosted by Wolper Jewish Hospital and Friends of Wolper. Our topic tonight is Ready, Set, Recover, Steps to a Smoother Surgery Journey. And as you may know, if you've come regularly, my name is Julie McCrossin and it's my great pleasure to be your host this evening. Our topic tonight is just so important. It's going to be an opportunity to hear from a number of experts what we can do to get the best possible result from surgery ourselves or to support members of our friends and family to get the best possible result. And so it'll be about preventing complications and promoting recovery. I'd like to begin by acknowledging that we're broadcasting to you from the land of the Gadigal people in Sydney and to pay our respects to elders past, present and emerging. If this is the first time that you've been with us, I'll just say that Wolper Jewish Hospital is a specialist medical, rehabilitation and palliative care hospital in the eastern suburbs of Sydney, and Wolper welcomes people from all cultural and religious backgrounds while offering care within the framework of Jewish culture, values, religion and dietary requirements. And I should say to you that over 70% of Wolper Hospital's patients are in fact not Jewish. It's a well-established private community hospital. Look, just before we meet our panel, it's always good for them to get a bit of information about you. And so we're going to run through 6 questions. How it works is it's a live poll. I will read the question, you answer it on your screen, and then our technical operator, Nat, will show us the answer. So let's begin with the first question on the screen. Gender. What is your gender? Male, female, other, prefer not to say. %, of men, 78% women, and that is the breakdown this evening. Thank you. And our next one is about our age group. Which group do you fall into for your age? 39 years old or younger, between 40 and 60, 61 to 74, 75 years or older. So there's no one 39 or under, 9% between 40 and 60, 28% between 61 and 74, and 63% 75 or older. Thank you very much. Question 3, please. Do you think the brain can be protected against the effects of surgery and anaesthesia? Yes, no, not sure. And we'll see our answers, please. 21% said yes, 19% no, and 60% are not sure. Thank you. And our next question. Effects after surgery. Have you or someone you know had their thinking affected or become confused or delirious, it's sometimes called delirium, after anaesthesia or surgery? Yes or no? Thanks, Nat. %56% are saying yes, they have experienced having their thinking affected or felt confused or delirious after anaesthesia or surgery, and 44% have said no. Thank you. Our next question has a big title. Pre-operative optimisation. Have you or anyone you know had pre-operative optimization? And what they're saying is that before your surgery, you've had access to an exercise program, a nutrition program, or psychological well-being support, preparing you for the surgical experience. Yes or no? Thanks, Nat. 19% yes, 81% no. Thank you. And our final question. Concerns and worries. To what extent did the preoperative education and information alleviate the concerns and worries of you and your family about the surgery? So did the information reduce your worries? Yes or no? Thanks, Nat. 43% yes, 57% no. Look, thank you so much. Thank you. That was incredibly interesting. It gives me great pleasure now to welcome our panel, and I'd like to welcome Dr. Christina Norris, geriatrician and perioperative physician at the Prince of Wales Public and Private Hospital. Hi, Christina. And Christina is the leader of the Care of Older People in Surgery service at Prince of Wales. Welcome also to her colleague, Dr. Taylor Scott, who is a staff specialist geriatrician at Prince of Wales, the network director, which means she's involved in training junior doctors, and also is involved here at Wolper Hospital. So welcome to you, Dr. Scott. Welcome also to Jenny Mackney, a clinical specialist physiotherapist at John Hunter Hospital in Newcastle. She's also a respiratory scientist and researcher, and we're going to hear about her research. And a big welcome to you, Jenny, who I know are enormously keen on preparing people for the surgical experience. And also Professor Bernhard Riedel, Director of Anaesthesia, Perioperative Medicine and Pain Medicine at the Peter MacCallum Cancer Centre in Melbourne. And so a big welcome to you. It's just great to have you all here. I'm going to start with you, Bernhard, if I may, Professor Riedel. Just before we begin, if you could turn on your microphone, please, Professor. Thank you. If you could just react to what you've seen from our audience, their level of reassurance before or access to preoperative support and information, just any initial observations about what you saw about our audience.
Julie, it's a privilege to join you, so thank you very much. It was interesting to see how few people have actually been prepared for surgery. And what's striking is, when we run marathons or get ready for sort of a 10-kilometer run, we often train weeks beforehand. And here we're going into surgery, which can be like running 2-3 consecutive marathons and not preparing for it. And so I think that's the striking component here. So we can do better, we can educate, we can get people optimized.
And I should say to our audience that each of our panel members have an extensive commitment and are involved as clinicians in preparing people for surgery, plus strategies to improve recovery after. So there will be detailed practical information throughout our session. But Bernhard, let's talk first about the incidence of side effects, difficulties out of surgery, because I was startled to read when I was reading a little bit about your work that you believe there's a hidden epidemic of complications and death after major surgery. And we are focusing tonight particularly on older people who may have a higher rate of complex comorbidities, and also perhaps on complex surgery. But even so, I got a little startled when you referred to a hidden epidemic of complications and death. What is the evidence to support that statement?
Yes, so Julie, there's a term, it's called a hidden pandemic, and it's often used in our literature. And what's quoted in the literature is some research that is done globally that showed the third leading cause of death globally after stroke and cardiac disease is actually the fact that someone's had surgery in the last 30 days. And it's often related to people needing surgery when they're in a critical state, needing urgent surgery, but often it's related to complications. So we often talk about two, drivers of complications, one being variability in the care, and we'll get onto that later, and where we try and enhance the recovery after surgery. And then the other component is we look for modifiable risk, where we can try and optimize patients, reduce the complications. So you may ask, what's the incidence of complications? It depends on the type of surgery. If you're having major surgery, as much as 1 in 4 patients will suffer some form of complication. And if we're talking about severe complications, whether that's a pneumonia, a heart attack after surgery, it's probably about 1 in 6 patients that can suffer these events.
That's amazing. Look, I'd like to ask Dr. Christina Norris to join us on screen, along with Bernhard, Professor Bernhard.
Christina's just gone to get her phone charger.
Oh, okay. Thank you. Sorry, we're having a couple of technical issues, but she will join us. I guess I might come to, excuse me, I just want to get the name correct. Dr. Taylor Scott. Can I have Dr. Taylor Scott join us on screen? And when Christina comes, we'll bring her on as well. And Dr. Taylor Scott works as a staff specialist geriatrician at Prince of Wales, as well as at Wolper. When we had our conversation, Dr. Scott, before this webinar, I was reassured to hear that if someone sees a geriatrician before surgery, they're less likely to have complications and more likely to be alive and at home 12 months later. And I suppose I wanted to bring that bit of information to the screen straight away before we talk more about the complications, just because we've got quite an older group, haven't we, with us this evening, and I didn't want to alarm people too much. But why is it that seeing a geriatrician, if you are older prior to surgery, can be so beneficial?
Well, I think some of those early questions clearly identified that some of the complications, particularly of delirium, are very common, and they're much more common in an older population. But importantly, and I think Bernhard's alluded to this, many of them are preventable. And so by seeing someone who has an interest, can be a geriatrician or a perioperative physician, in identifying the risks and working proactively to reduce them, it certainly can mean that people have a better recovery after surgery.
So we'll come to more information about the care of older people in surgery service that you're offering at Prince of Wales, to get a sense of the kind of comprehensive preparation that is available. But coming back to you, Professor Bernhard Riedel, can you give us a sense of what some of the key complications are that are modifiable, in other words, that we can do something about prior to surgery, but just so we get a sense of what those complications can be?
Yes, so Julie, often it can be it could be pneumonias, so we can try and teach patients breathing exercises before surgery to try and reduce or improve lung capacity. Functional capacity is a key component of keeping, in other words, the level of fitness. And if you go into surgery feeling or being a lot fitter in a well-nourished state, your complications reduced by, in some of the evidence, is nearly half. And so working with our allied health colleagues, if we can identify, risk stratify, find out who's got deficit in terms of functional capacity, deficit in terms of nutritional and even psychological well-being, and then educate and bring them along to optimize them with an exercise program, optimizing their nutrition, etc., working with our geriatricians, trying to reduce the risk of postoperative delirium. So it's a range of complications that make up these. It can be any organ that's affected.
And you mentioned the term, I think it was optimization, but this notion of making some form of individual assessment of someone prior to surgery. and therefore being able to target these interventions that we're going to hear about tonight more precisely. Stratification, that was the word you used. I was trying to remember. Can you just tell us, what are you doing at Peter MacCallum? Obviously, I know you're dealing with people with cancer there, but as I understand it, this approach applies generally. Can you explain what you're doing there to try and identify individual needs? And we have had a message asking you to both speak up, if you could, please, from our audience.
So what we've got is tools that we use for those who are having major surgery, whereby we can screen and, for example, ask them about their fitness level. Those that have impaired fitness levels, we can often test them with a 6-minute walk test, or at times sit to stand, or as much as cardiopulmonary exercise testing, which is Jenny's expertise, and try and identify and objectively quantify how deconditioned, how much opportunity there is for improving fitness, so that we can try and modify that component. So risk stratification using various tools, also for nutrition, we'll identify them so we can refer those with deficits onto our nutritional colleagues.
And just before we go on to action to address modifiable risk factors, are there risk factors you can't modify but that are important to recognise?
A lot of our medical comorbidities, and that's where our geriatrician colleagues will come in, is trying to help optimize the things like diabetes, heart disease, making sure that those medical conditions that you have are in an optimal condition. And so they're not necessarily modifiable. You can't necessarily always get rid of them, but you can make sure that they're in an optimal, well-managed condition. So you enter surgery in a tuned condition.
That's fantastic. Could I invite Dr. Christina Norris onto the screen to join us? And welcome, Christina, and thank you for your efforts to join us. Just a reminder, Christina is a geriatrician and a perioperative physician at Prince of Wales Public and Private in Sydney. Christina, just tell us what that word perioperative means. It's like prehabilitation. There's always these two words we need to learn, but can you explain what perioperative means, please?
Absolutely, and thank you for having me. It really just means around the time of surgery. So we're really covering that period leading up to surgery, during surgery, intraoperatively, immediately post-operatively, and the recovery afterwards. So it's a relatively new concept, having a perioperative physician, but it's something that I think patients will increasingly find they will be able to have access to.
I want to come to delirium in a moment because that's such a significant issue for older people, and we clearly have an older audience tonight. But could you just describe the care of older people in surgery service that you and Taylor Scott are involved with at Prince of Wales, please?
Yes, of course. Look, not many people may know, but for a long time now, if you come into hospital with a hip fracture, an orthopaedic surgeon and a geriatrician throughout most places across the world will look after your care. And that's because people with hip fracture almost universally undergo surgery. We decided with our program, Care of Older People in Surgery, COPS, to take that idea to other surgical populations. So for patients who are coming in with bowel obstructions or bleeding from the bowel, they now routinely get care from myself or Taylor as well as the surgeon, and we share the care together. And by doing that, we have seen that we've had a substantial reduction in complications for older people, halving of the rate of delirium. People do better as a result of this collaborative care model.
And Bernhard, communication is another one of the key issues you think is so important for the preventing of complications. Just to build on that point, particularly between the patient and the surgeon, as well as between the multidisciplinary team. Could you just speak to that thing of shared decision-making with the patient and the role of family?
Yeah, so Julie, we often talk about universal prehabilitation, so that's education, and that communication component is important. across a universal for all patients. But there's a component of patients that are probably due to have major surgery, who carry a high burden of comorbid disease and probably at higher risk of complications. And that cohort of patients often require a shared decision-making clinic. And there's a number of these clinics around Australia. Not every hospital has them, but there's various services that probably align to these complex care clinics. And in those clinics, it's the opportunity to elicit the goals of the patient, what they want to achieve out of their surgery, and then make sure it's aligned with the evidence for the benefit that may be obtained from the surgery, the risks that are associated with the surgery, and make sure that the goal and the intentions are congruent with each other. And at the same time, discuss whether there's alternatives to therapy. Because if the risks are too high, it may be that we shouldn't undertake surgery. It may be that we undertake a lesser form of surgery, often referred to as sort of palliative type of surgery, which is just not a curative intent, but still modifying outcome. And then importantly, exploring in the cancer setting whether there's radiotherapy or whether there's other chemotherapy as alternatives to therapy. So to avoid decision regret in terms of having surgery and then having major complications that weren't anticipated and weren't discussed. And so therefore, I think that's where shared decision making comes in, eliciting goals, understanding the risk benefits, and then coming to a shared conclusion.
If I could bring you in, Dr. Taylor-Scott, one of our geriatricians, because I know you care enormously about the role of the family and working with the family. Why is that important? I must admit, I'm saying this not only because I assisted my late mother to her the end of her life in her middle 90s, but also I've actually had cancer and I've had the impact of the effect on cognition of my cognitive capacity of shock and then later medication. Mm-hmm. So what's the role of the family when we're talking about reducing complications?
Integral, I think. We haven't really touched on delirium a lot yet, but certainly having family involvement, we know, can substantially decrease the risk of delirium. But even taking a step back to what Bernhard's talked about in shared decision making, I think having family involvement in that, because often we're talking about very complex decisions and difficult recovery that family will need to help support. So I think from the get-go, when we're considering surgery, having families involved in that shared decision making, and once the decision's been made to proceed with surgery, involving them in your perioperative plan can help reduce your risks, and particularly of delirium, which I'm happy to expand on, but
yes.
But particularly of delirium, yes.
Look, I'm mindful of questions for our audience, so I might take a question from our audience, and then when we come back, we'll discuss delirium more thoroughly, and I'll also welcome our physiotherapist whom we have in the wings. Oh, here she is. Welcome to Jenny. So I'd like to welcome Dr. Carmela Milka, who has been looking at the questions that people have sent in advance and also coming in tonight. Carmela, can you share one of the questions with us?
Yeah, so actually one of the audience asked now, which I think is quite relevant. One of the questions asked was, if somebody's having shoulder replacement or shoulder surgery, how can one access perioperative care or access to the physician?
Christina Norris, can I ask you to answer that?
Yes, of course. Look, so I'll be honest, it really depends on where you are, because the sorts of concepts that we're talking are not yet universal across Australia, across every hospital. It really does depend on where you go. I can tell you in my experience, we're very lucky here at Prince of Wales Private and also across at Wolper. There are perioperative physicians like myself who can assist with that process. So I very frequently often do see people coming up to having shoulder surgery. And I think it's a really important thing to think through, because it's not actually just the surgery, the recovery afterwards, in particular how you manage with one arm out of action, so to speak, particularly if you're right-handed and it's your right shoulder, can actually be quite challenging. There are very definitely supports out there, and planning in advance at the very least, to know how you can get through that whole period of time is important.
And we are going to hear a comprehensive approach to planning for after surgery a little bit later. Christina, I think you would have seen the poll answers when they were coming through earlier. And a substantial proportion of this audience have not had access to information. That's what they're reporting to us. And we do have an audience, not exclusively from the eastern suburbs of Sydney, but substantially. Did that surprise you, what we saw today?
No, unfortunately not at all. And, often what I say to patients that I see is a lot of this is not rocket science. A lot of it is common sense and just getting the basics right. And I think, unfortunately, because of some of the aspects and the amount of information that's out there about some of the technical aspects, those real basics that not just count for your overall recovery, but particularly for your brain health, often do get missed. So it is something that, and I'm sure, Bernhard would very much agree, it should be universal, but unfortunately at this point in time, it's not.
Well, I quoted you earlier that if you see a geriatrician before surgery, you're less likely to have complications and more likely to be alive at home in 12 months' time. At what age do you classify as having access to a geriatrician?
So officially, anyone can access a geriatrician, but in order to access the specific comprehensive geriatric assessment, as a general rule, your GP would refer you to a geriatrician. And this is it takes about an hour to do, but it's a comprehensive assessment where we go over your background, your medications, we look at your function, but most importantly, we go looking for things that potentially can derail your independence down the track, but also things that are important to you. And we develop a plan with you based on what is important to you. And that, we know, in surgery is what seems to make the difference, having that tailored plan, but with that focus of surgery in particular.
I guess for the obvious question is, if you're watching this tonight and you haven't been offered that support, particularly if someone is watching tonight because they've got surgery approaching, what do you do? Obviously, I'm left thinking the healthcare system needs to lift its game in terms of what the data and evidence you're describing. But just for people right now, and I'll ask Dr. Scott if you could come on as well. Dr. Taylor Scott, I know you work together. What is your advice to people whose surgeon is not offering these options?
Well,
often we take our doctor's advice, don't we?
Look, I think the reality is access to geriatric medicine is still, again, a challenge, even for those not undergoing surgery, those just looking for, say, a diagnosis about why their memory might be an issue. So it is very definitely a gap in our system. But I think for the most part, a lot of hospitals, not just the public setting, but the private setting as well, will very definitely have some access to geriatricians. I think, it is something that we'll certainly see increasingly in time. And, as I mentioned before, for decades, orthopaedic surgeons have been working collaboratively with geriatricians, but increasingly surgeons of other specialties recognise the value in that. And, I can tell you from Taylor and I, our experience at Prince of Wales, we now have a bit of a system of the haves and have-nots in terms of the surgical departments that say, oh, I want that shared care service. When can you come and do it for us as well? So I think there will be a shift, but these things very definitely take time. And, the idea of seeing a geriatrician is not something that I think most people think of as a great idea. You don't want to be thought of as geriatric, right? So.
Well, can I come to you, Taylor Scott? If I could just say, I'm 70 and I'm interested in having the best functional capacity, as I've learned to call it, for as long as possible. So I would like you to change your name. I'll be honest with you. Right now, I'll accept geriatric if I get the care. I'm going to, in a moment, bring in Jenny, our physiotherapist from Newcastle. But I just want to say, does it have to be a geriatrician? Like, if we're wanting this kind of overall assessment and we can't access a geriatrician, what's our other alternative?
So I think someone who has an interest in perioperative medicine, and that in different areas of the country, that can be different specialists. Often it can be general physicians or geriatricians and some anaesthetists as well. So it depends on what's available in your local area, I think. But it doesn't necessarily have to be a geriatrician, but someone who has an interest in caring for people before and after surgery and an understanding of what the risks are and how to reduce those risks.
Could I invite Dr. Jenny Mackney onto the screen, please? And Jenny, you'll remember, is a clinical specialist physiotherapist at John Hunter Hospital. She's also at the University of Newcastle as a lecturer in health sciences. And I know, is there a physiotherapist alive who isn't passionate about exercise? And you told me that it's good for everything. But it's particularly important, isn't it, in this preparation for surgery? So as you listen to this discussion about access to help, that issue of access and equity of access is very close to your heart. Tell us what's happening at Hunter and what you'd like to see happening all over.
Yeah, absolutely. Exercise is, as you mentioned, important for general health and well-being, and we encourage everybody to be involved in exercise program, especially given the guidelines around physical activity. Exercise prior to surgery, and my experience is very much in abdominal surgery and particularly around cancer, so resection of cancer. We know that
resection.
Oh, sorry. So surgery for removal of cancer and management of cancer. Yeah. And we know that exercise training, particularly aerobic training in this sort of group, if you're having that type of surgery, can help to reduce respiratory complications, particularly after surgery, and also reduce your length of stay. So for example, for a large operation, it might reduce your length of stay by up to 2 days. But of course, and we've talked about already, access to services and access to prehabilitation, and exercise-based prehabilitation is really challenging.
What do you mean it's challenging to get access to it?
Yeah, that's right. Yeah. To get access to exercise-based prehabilitation, ideally you would be linked with a physiotherapist or an exercise physiologist to provide a tailored exercise program in a supervised setting, particularly for older people, and particularly if you haven't exercised previously. There can be some fear around exercise and concern and not sure, and some and being unclear as to what type of exercise might be beneficial. From a public health perspective also, access to exercise training before surgery is really challenging. We don't have Medicare funding for exercise prior to surgery. For people, particularly in regional and rural areas, it can be really hard to access the hospital on a regular basis to access exercise programs, and prehab exercise programs aren't available in a lot of hospitals. Similar to perioperative geriatric care and all prehabilitation, it's taking time for the health service to catch up a little bit.
I must say, I want to turn to what our audience can do, because obviously that's why they've tuned in and will tune in. We had over 100 and around roughly 140 registrations, and they will all get a recording of this evening's discussion as well. It'll go on the Wolper Jewish Hospital website, and I'm certainly intending to promote it like mad. And I just want you to know I rang my exercise physiologist today and have rebooked for the next few weeks just for preparing for this activity. But I just wanted to quickly say, this is what I've heard tonight. If a person could afford a physiotherapist privately, it sounds like it's worth talking to your general practitioner or your surgeon, but certainly to your general practitioner, and say, are you aware of anyone I could access who's a physiotherapist or an exercise physiologist who's got a particular interest in preparing people. I can see the two geriatricians nodding, just because, if we can't get a geriatrician, someone who's like yourself, Jenny, would also be immensely helpful. Just before we go to this question, to another question from the audience, and then we'll do delirium, I just want you to explain the 3 pillars of prehabilitation. What does that word mean, and what are the 3 elements of it?
So the 3 pillars of prehabilitation incorporate exercise training, psychological support, and nutritional, good nutrition. And they're all very synergistic with the aim to improve physiological function. And so you're in the best physical shape leading up to the operation so that your recovery is optimized as well.
So the lower your fitness, the higher the risk of complications.
That's right. And conversely, the fitter you are, the lower your risk of complications. Yeah, that's right.
Professor Riedel, can I ask you your comment?
Julie, I just want to make 2 comments. While it's sounding like we don't have these resources, and it's true, we are seeing directional movement in the right direction for scaling access to perioperative medicine and including geriatrics. So the colleges around the country and led by the College of Anaesthetists, but in conjunction with the College of Physicians, the College of Surgeons, etc., have created what they call now a postgraduate diploma in perioperative medicine. And more people are being trained in perioperative medicine to support the elderly population that are having more comorbid disease, etc. Other areas where we're researching scaling prehabilitation is getting patients referred into the community for exercise physiology, for physiotherapy, and one of our novel areas of research is actually developing a telemedicine hub whereby we can use the physiotherapists, the dietitians, the psychologists, etc., to support the regional rural patient through central hubs. And so we've got an exciting hub developed here at Peter Mac that's going to service a number of hospitals around us in conjunction with a hub in Sydney. And so patients can be referred into these hubs, be prehabilitated, referred back to their regional hospitals for surgery. Now, that is a research project. It's not yet a service that's available.
And it's a research project with the Royal Prince Alfred Hospital in Sydney. I mean, that's correct, isn't it? It's so interesting because you're at Peter MacCallum Cancer Centre in Melbourne. Does that tell us that you're researching it because you have a passion for this topic, and that at the moment it's the people with passion who are advocating to address the needs of this so-called baby boomer bubble that I've been seeing at conferences for 20 years. That's why I'm a bit surprised we're not a bit more ready for the bubble coming. I'm a bubble member and I need you.
And so that's right. We've got to find scalable solutions, and that's where telehealth is one of those important, and leveraging the community resources that we can link in with.
Can I come to ask Camilla Milker, our general practitioner, to come onto the screen with the group, if I may, and just say, have we received any questions in relation to delirium or other cognitive issues, just out of interest?
Thank you. We actually have one question that was asked before the webinar was, do numerous anesthetics affect memory in the long term? And another one was, does recovery time extend with age?
Okay, look, thank you. Well, we come, Christina, Norris, to the one about cognition first, and perhaps have a thorough discussion about delirium at this point.
Sure.
So your response to the question, thank you.
Yeah, look, I think to be honest, it's a common misconception that it's the anaesthetic that is the problem. You know, we talked about a lot of people are aware of the fact that after surgery, they or a loved one have sort of, been a bit confused, maybe even had some hallucinations. Maybe it's been a bit scarier than that delirium. But the reality is, when your body put through a physiologically stressful process, surgery and anaesthesia is exactly that. You're not asleep, your body's working quite hard. When the body is under the pump, the brain is under the pump. And that's what we see with delirium. It's this acute change in our thinking, which in its mildest form might just be some difficulty concentrating, but when it gets more significant, can be fear, paranoia, hallucinations, not knowing where you are. It can be a very scary process for the individual and people around them, but it is a temporary process. It peaks at about 48 hours after surgery, and from there generally gets better. But it is something that we don't talk about very often, and there is a lot of fear, I think, out there in the community.
Can you, if I could invite Dr. Taylor Scott to join us as well, I'd like to interview you together because I know you work together at Prince of Wales Hospital. I've seen someone close to me with delirium, and they almost seem to change physically, even their facial expression. Can you explain, Taylor, just for family members watching, what the impact it can have on families to witness family member or friend in a delirium state, and what they can do to assist that person in the acute phase and later to recover? And I'll come to both of you, if I may.
So I think you're right, Julie. Even when I've had family members who've had delirium, even though I see it every single day, it was still terrifying to me. And that's because it can be such an abrupt change in multiple domains of our cognition. So people can be disoriented, not know where they are, their memory can be affected. And as Christina said, they can have things like hallucinations, or sometimes it can go the other way, that people can be very drowsy, hard to wake up. And one of the features that really defines delirium is that it fluctuates. So there might be moments where people are very good and moments where they're more confused. And for a family member, that can be quite distressing because you think someone's recovering and then they can have a period where they might be more confused again. And it does, for that initial period, fluctuate up and down. And that's part of what defines delirium. But as Christina said, it is temporary. And usually as you treat or reduce the factors that are contributing to it, it improves. And where families can come into that is, I like to refer to it as giving the brain as many normal signals as you can, particularly when you're in hospital and you're in an unfamiliar environment. So simply having a familiar face and a familiar voice at your bedside can be, incredibly important to help give those brain the normal signals. It sounds so simple, but things like having your glasses on and your hearing aids in helps. So it's all about giving those brains the normal signals. And unfortunately, this is stuff we should do for every patient in hospital, but we don't do very well. And families can really advocate for patients and be the one to help make sure their glasses are on, make sure their hearing aids are in. I'm sure Jenny will advocate for this. Getting people up and moving early not only is good for their physical recovery, but it's very important for their brain recovery as well. And we know that getting people up and moving reduces their chance of delirium as well.
Christina, we heard when we did our poll that quite a number of people who are watching this webinar have experienced cognitive difficulties associated with surgery. What words of, first of all, I don't think we've given the incidence, like how common is it to have delirium, but also how common is it to have longer lasting effects, just so we know what that's what the evidence is there.
Absolutely. Look, the evidence varies, and it varies depending on surgical procedure, whether it's emergent or elective. But as a general rule of thumb, 1 in 5 people over the age of 75 having surgery. But depending on the surgery, for example, cardiothoracic surgery, up to 50% of people have delirium after surgery. So we're talking about one of the most common, if not the most common, medical complications after surgery. So it's not an insignificant thing. In terms of long-term cognition, the reality is we do see it a little bit more commonly in people who have some underlying cognitive decline, but not universally. And I often say to patients, the evidence is not really crystal clear in this space. But as a general rule, if you've had a particularly prolonged and severe delirium, people don't always find their thinking goes quite back to 100%. In my experience, most people do come about 12 months. But there's nothing to say that it causes dementia per se. It's just that we know that delirium can be certainly a little bit toxic to the brain if it is prolonged and severe.
And when you say prolonged, how long?
Look, potentially weeks even. Most people experience delirium that would last for a matter of days, but there are unfortunately some instances, particularly say if that individual's body is still really under the pump, really unwell with complications, where it can linger. Similarly, in certain circumstances, Parkinson's disease for one of them, we don't infrequently see a prolonged delirium after surgery. I think, the other thing that is important to say, though, is this is not a foregone conclusion. There are absolutely things we can still do, not just to prevent delirium altogether, but certainly lessen its severity and try and avoid that prolonged period afterwards as well.
What I'd like to do, if I could bring in Jenny Mackney, our physiotherapist, to join us on screen as well, because I know you, in part of that preparation and seeking to prevent delirium, exercise is part of it. So can you talk to the exercise side of it? And then I'd like to hear other steps of what people can do to prevent or reduce the likelihood of it.
So exercise is great for to prevent delirium, as we've heard. Getting up as soon as possible after an operation helps to reduce the risk of delirium, but also...
Fascinating. Why? Is it because you believe in breathing deeply as soon as possible too? Is it about oxygen to the brain?
I'll let the geriatricians answer that one.
Taylor, do you want to answer that?
Well, Christina, look, I think it's probably multiple things. I think it is, getting back to your normal routine. I think it's often, when, particularly in hospital, when people are in intensive care, they often know windows in that environment. Whereas if you get up, you get moving, you have access to daylight, all of those things are important for preventing delirium. So I don't think it's necessarily one thing. I think it's probably the cumulative effect. Christina might have a more scientific answer. That would be my sort of initial response.
There are very definitely some signs, and this is not hard and fast. There is no strong research base to support this, but we certainly know the process of standing up and of sitting up and moving around wakes up the brain, if you like. It gets certain neural pathways going, and those pathways very definitely are important to assist in terms of allowing the brain to work as well as it can. But as Taylor said, it is, with all of delirium, it is never just one thing. It is getting everything right.
Just, Jenny, if you could talk about why you think it's so important to start breathing in terms of recovering from surgery.
Yeah. So particularly with particular types of surgery, and if you have lung disease or any thing that might contribute to an increased risk of lung complications after surgery, starting to do deep breathing and coughing exercises as soon as you wake up is really, really important, and we know can halve the risk of lung complications such as chest infection and pneumonia post-operatively. And the reason that we think that starting it as soon as you wake up in recovery is important is that if you develop a lung complication, it usually happens in that first 24 to 48 hours. And the physio might see you on day one and get you out of bed and moving and do some deep breathing exercises. But if you can start doing your deep breathing exercises and coughing to clear any secretions, you can reinflate any collapsed areas of lung as soon as you wake up and help to prevent those lung complications before they actually set in.
And Dr. Taylor Scott, you told me that it's important to recover at home if as soon as you're able and if you're safely able to do so. Is that part of, well, why is that important?
Well, it's probably multiple things. I think, again, going back to delirium, Christina and I clearly have a passion for it. We know that being in your usual environment and routine is protective for your brain and helps your brain recover. I also think people underestimate when they're in hospital. And obviously I work at Wolper and think Wolper is fantastic, but the amount that is done for you, you know, every cup of tea, every meal is brought to you in hospital. And so you end up doing a lot of less incidental exercise. Whereas I think when you're at home, you tend to naturally increase the amount you're doing. So often getting back to your own environment sooner means you tend to get back to being more active than you would in hospital. In hospital, people spend a lot of time in bed or the chair, unfortunately.
And Christina, just before I bring our anaesthetist in to give his comments on delirium and other matters, would it be helpful when a person's in hospital, if they have delirium, to bring in familiar objects from home, even photos of the family or a favourite image? Or I'm just trying to think of the ways to try and remind them who they are, because when I saw my family member, it was almost like they'd forgotten who they were.
I think it's a really good point. And you know, just as Taylor said before, it seems simple and it seems like it shouldn't have that much of an effect, but it does. That familiarity, not just in terms of the environment that you create around you, but, you know, I like to say, you know, a familiar face is better than any drug I can give. Yeah. And it's not just that reassurance and orientation that family member is giving. It's because, you know, you'll be talking about things of, you know, where are we right now? What is going on? But also if you can then sort of refer to things in their environment that can settle them down, make them feel more at home, it just takes away some of that clinical aspect of being in the hospital, because that environment is, as we say, deliriogenic. It contributes to delirium in and of itself, which is why being at home is so much better. And in fact, when people have a severe delirium, we often sort of say, look, you know, if we can just get you back to even 80 or 90% of what you're normally like, getting you back into your own environment will be the thing that actually brings you back. It's so important.
Look, I'm going to invite Professor Bernhard Riedel to come on, and your comments, sir, in relation to, as an anaesthetist, in relation into both the prevention and recovery from delirium. Would you see some of your patients when they wake up?
Julie, there's a phenomenon called emergence delirium. So as you wake up, and as we've heard from Christina and Taylor, it's typically 24, 48 hours that it's short lasting. The impact that anesthetic techniques per se, there's some data out there. There was a Chinese study who randomized 1,000 patients to gas anesthesia versus intravenous anesthesia that we give through the veins, suggested that there was a reduction by, now we say 30%, but it was down from 12% incidence to about an 8% incidence in an elderly patient population having major surgery, so 65 years and older. So fairly common, that as Taylor, the incidence said, you know, 1 in 5, somewhere in that range could have delirium, short living delirium. What we as anaesthetists can do is try and prevent using long-acting drugs, maybe consider monitoring the depth of the anesthesia, making sure we don't give excessive drugs, keeping the blood pressure, because as our blood vessels get older and more calcified, keeping the blood pressure at adequate levels that's tailored to the individual patients is sort of what we call street blood pressure, as opposed to a minimum blood pressure. So these little incremental gains that we can contribute to trying to prevent delirium in the post-op period. But the aspects that have been addressed about familiar faces, familiar environment, hearing aids, cognitive aids, etc., are crucial in the post-operative period.
And I just wanted to ask you about the importance of knowing the pathway in recovery. I'm just trying to move the conversation a bit more to recovery before I promise I will come back and do a row of questions from our audience. But I know that you're part of advocating for ERAS, which is enhanced recovery after surgery. Could you just tell us a little bit about that, Bernhard, and why it's good for us to know about it?
So, Julie, whether you call it a perioperative medicine framework or whether you call it enhanced recovery after surgery, I think we need to try and reduce variability in care just as much as we want to try and reduce modifiable risks and optimize patients. From a clinician point of view, the pathways in hospitals, there's a lot of variation in the care that's delivered through the whole perioperative journey, so pre, intra, post-op. And that's where enhanced recovery after surgery comes in. These are typically, it's an international society. People contribute to the pathways. They look at the evidence and say, right, for example, for major bowel surgery in the preoperative phase, we should try and optimize, educate, minimize the starvation or the period without fluid before surgery, intraoperatively short-acting drugs, good painkillers, post-op early mobilization, early feeding, try and remove as many of the tubes, the nasogastric tubes, the urinary catheters, etc., and try and keep people on a trajectory of recovery. And that's what ERAS is. It's a pathway of best practice, of evidence that we try and keep patients on to ensure that there's progress, that there's recovery.
Just one more question I wanted to ask, and that is, quite a number of the people in our poll reported some cognitive issues tonight. And I'm just thinking, if they are needing surgery in the future, is it important, and I might get a comment from Christina as well, but starting with you, Bernhard, is it important to let your surgeon know if you've had a prior cognitive impact? Because we can't always rely on the notes, can we, that the record is whizzing about.
I think it's very important, and therefore the surgeon will then work with the periop medicine team around him or her, and then help optimize the patient, identify whether there's any deficit through screening tests, and then work with the periop physicians, the geriatricians, etc., to try and put these pathways in place to minimize the insult and expedite the recovery.
And to talk to the anaesthetist, because as I listen to you, there's clearly some things that an anaesthetist who's been properly briefed, working in partnership with the surgeon, can do to lower that chance of delirium. Having seen it, I have to admit I'd like to avoid delirium if I possibly could. I think a lot of us fear that loss of cognitive strength, don't we? But Christina, did you want to comment on that in terms of what patients should tell their doctor if they've had prior cognitive or other surgery-related issues?
Absolutely. And we know that if you've had delirium in the past, that is a very strong risk factor for having delirium again. But equally, even just being mindful of some memory changes or any concern about your thinking is important, because just as Bernhard said, we can monitor the depth of your anaesthesia. The intraoperative drug choices can also potentially avoid some that we know are associated with delirium. But equally, if you're on some benzodiazepines or sleeping tablets or drinking alcohol, perhaps more than a couple of glasses a day, those are things that are very, very important. But coming back to
stop before surgery.
Very, very good point. We do find that sleeping tablets are used very broadly in the community. But funnily enough, if you suddenly stop them, that actually can cause delirium in and of itself. You can withdraw. And so I would say 9 times out of 10 when I'm asked to see someone, no memory problems before, but now they've got a post-operative delirium, a lot of the time there is a withdrawal component to these sleeping tablets or alcohol potentially. So it's cutting down where you can. It's not stopping anything cold turkey, and certainly with, not without advice of your treating GP. But these are medications that very definitely can have ramifications after surgery as well. I do also, though, want to come back to the collaboration side and the conversation side. I think the key thing in this space is we make better decisions. And I don't mean just patient clinician, but us as your clinical team make better decisions when we communicate. So as part of that routine, comprehensive geriatric assessment, if I'm worried about someone's thinking, I talk to the anaesthetist. And Bernhard, maybe you can comment on this. This idea that if you've had one general anaesthetic, it's going to be the same as the other is actually not true. Every, anaesthetic is a cocktail of different things. No one is alike another. And so just simply that anaesthetist being aware of that risk means that something happens in that black box, that the patient comes out better afterwards on the other side. So those, I think, are the key things that are important, both to tell your anaesthetist, but, just being mindful of as well.
Did you want to comment, Bernhard?
Christina's spot on. Anesthetics is a combination of multiple drugs. It's around antibiotics, anti-nausea drugs, painkillers, sedatives, keeping you asleep, muscle relaxants, etc. And so the choice of all of these drugs, that we administer, anything between 10 and 20 different drugs in that short period, but also the resumption of the chronic medications are all extremely important components. So absolutely, we need to have those discussions. We need to understand who's at risk. We need to screen for delirium risk and then work with our colleagues around the peri-op space to minimize.
Look, what I'd like to do now, we've got half an hour left or 25 minutes, is to answer as many questions as possible. I think my own fascination with this has caused me to ask too many questions. If I could ask Dr. Carmela Milka to join us and to tell us some questions from the audience, please.
Thanks, Julie. So one question has been, can painkillers cause delirium?
Okay, I might get is Christina there, please?
Sure. That's a really good question. And I have to say it's one I actually really like answering when I get asked it, as I often do. To be honest, we actually know that pain is much more likely to cause delirium than pain medications are. In actual fact, you really want to find the sweet spot in the middle. You don't want to be in extremes of pain, but you equally don't want to be doped up. That being said, there are very definitely people who are more sensitive to particular types of opiate analgesia in particular. So it is important to be mindful, but it's so important to control pain. You're much more likely to end up with a situation, either delirium or pneumonia because you can't breathe so well, if you don't control pain.
Okay, thank you. Another question, please, Carmela.
So another one is about aggressive behavior and delirium.
Thank you. Christina, if you could, and perhaps Taylor Scott, if you could come on together and run through a few more of these symptoms. Aggressive behaviour, one that I've observed was urinating in public, something a person would never normally do. So some of those issues, if you could describe how common they are.
Taylor?
Yeah, look, unfortunately, we do see sometimes aggression or even paranoia, hallucinations when people have a severe delirium. And as you say, Julie, it can be quite out of character for that person. And it's very distressing sometimes for that person if they remember it, and particularly for family and friends around. So that's why it's so important pre-operatively, if we get the opportunity to talk about delirium so that people are prepared. I think if you know about it in advance, it can reduce that fear and anxiety around it. And hopefully we can do some things to reduce the risk. But it certainly can happen. But I don't want this to terrify people. And I think, anaesthetics often get a bad rap about it being the cause of the delirium. It's often everything around surgery that can cause delirium, but not every patient gets delirium, and we can do things to reduce it. So while it can be very scary when it happens, as Christina said, it's not a foregone conclusion, and there are things we can do to reduce delirium post-operatively.
What can you do, Christina, post-operatively to reduce delirium?
Well, again, this is evidence that's been around for 20 years. It's not rocket science. It's getting the basics right. And it is, just as Taylor said, making sure your eyes and ears are working, so you've got your glasses, your hearing aids on, controlling pain, as I've said, eating and drinking. If you're not getting energy to the brain to function properly, brain won't work quite so well, making sure your bowels and bladder are working well, getting up and moving, and then just, again, creating those environments that help the brain. A familiar face saying, hey, Mum, you've had hip surgery, you're in hospital. I know, there are some scary things happening, but you're safe. I'm with you. You're in hospital, you're doing well. Having familiar objects around you, so if they do wake up, and say, oh gosh, where am I? This doesn't look familiar, but they see that clock that always sits by their bedside or that photo frame of a loved one. Those are the simple things that go a long way. That combined with orientation, cognitive, we say rehabilitation and stimulation. So whatever it is, whatever brain activity you do at home, doing that in hospital, that's all you have to do. We as geriatricians very definitely do our best to create that personalised delirium prevention plan for you, and we know that's effective. I can tell you in my own experience, in our research, we halve the rate of delirium after surgery just by using that approach. But in the elective setting, having elective surgery, we could certainly take it further. But at the moment, the jury's a little bit out on exactly how we can do that as perfectly as we do.
I think if I could say, my instinct is that assisting the person to start going to the toilet on a toilet is important, because you're encouraged to be in a bedpan sometimes, and so then you're actually weeing and pooing in bed, which is, you know what I mean, that's really confusing for people. I guess I just want to have a quick comment is, having spent a lot of time in hospitals with my mum over the years in 4-bed rooms, there are people who don't get visitors. And that means that not only are they obviously more vulnerable, but also they don't have the family to be able to say to the staff, this isn't what my mum's like. She's normally quite intellectual. She listens, whatever. She's a businesswoman managing some rental properties, but now she's weeing on the floor, whatever it is, So are hospital visiting schemes, or are people just more vulnerable? And there's not much a doctor can do about it.
No, look, that's a really good point again. And actually, this hospital elder life program model, which is this 20-year-old delirium prevention program I've just mentioned, actually it's an American program. And as part of that model, they used visitors. They used volunteers who were visiting the hospital to assist in making sure that patients got those basics right, so that if they didn't have relatives, they had someone there who could help them do that. Look, it is a shame. As I said, we should be getting the basics right, but it just doesn't happen. And hospitals these days are just very busy environments. So, look, it can be very hard for those who don't have loved ones. We do not do the volunteer aspect that well, unfortunately, in Australia.
I was just thinking, pastoral care people are at hospitals. They, given the baby boomer bubble, I mentioned earlier, this large number of ageing people coming up to their 70s and 80s and 90s, giving training to those pastoral care workers in delirium and what they can do to help orientate people. If I could just make that practical suggestion. When I was a young girl, part of what was called then charity work at the school I went to, it's now called human rights work, was that we did hospital visiting, and we got some training as, year 11 and 12 students. And again, they could, if there's those sorts of visiting programs, they could be trained to check the person's got their glasses and their hearing aids in and the volume's turned up. I'm just trying to think of some ways of handling it, because there's a lot of people with family breakdown.
And there's lots we can do at a system level. So I think Bernhard was talking about these ERAS pathways, or these enhanced recovery pathways. A lot of the things that are incorporated in that, like removing, if you have a tube feeding you, or removing a catheter, and part of that is getting up and getting moving, having a more structured systems approach to people's recovery that we all incorporate with every patient every day can also definitely help reduce delirium and other complications. So while that personalised one-on-one is often the best at an individual level, there's definitely things that we can be doing on a systems and structural level that helps all parts of recovery, and delirium would be part of that.
Carmela, if I could come to you for another question, and also if there are any relating to when the person goes home, that would be of interest, but whatever question you've got ready to go. Thank you.
Yes, I've got quite a good one. How long before a procedure should one prepare?
Okay, good. May I come to Bernhard initially, and then I'll come to both of you, and to Jenny. Bernhard Riedel, could you answer that? When should this prehabilitation begin?
As soon as possible. But in essence, it's never too late. But it depends what you want to achieve. If it's a major abdominal surgery, and we'll have Jenny join us and comment on that as well. But we start seeing benefits of exercise after about 2 weeks of exercise. Ideally, we want to see about 4 weeks of exercise. But nutritional aspects or just a breathing exercise that Jenny described so well, it takes 30 minutes before surgery to do that. So it depends where you are on your journey. Often you on a waiting list. We shouldn't see these as waiting lists. We should see these as preparation lists in which we do our best and to optimize ourselves, and therefore visiting your GP, checking that your blood levels, your iron levels, etc., are normal. So it's hard to give it a definitive sort of timeline, but as soon as possible, get yourself optimized. There's much that can be done.
Just say something about frailty or unanticipated weight loss or malnutrition. You know that a lot of older people, we can get thinner and frailer and less keen to eat. So how should that be addressed prior to surgery?
So most hospitals have got screening tools for that. They ask questions around weight loss, loss of appetite, and that often triggers a referral to a dietitian. And trying to get patients optimized, the nutrition is extremely important. But in terms of prehabilitation with exercise, for example, your best time to build muscle is actually to ingest protein after your exercise. So within 20 minutes after exercise, a bit of protein goes a long way.
Okay, thank you. Jenny Mackney, a physiotherapist, I could bring you in from Hunter, New England and Newcastle. Give us a couple of examples of patients that you've worked with, what their surgery was and what you feel that prehabilitation, this exercise, nutrition, psychological support, what it contributed to their recovery.
Absolutely. So the space that I work in is cancer. So the example that I will give is around esophageal cancer, for example. And the normal pathway to surgery for that type of cancer is a period of chemotherapy, plus or minus radiotherapy as well. And then there's a period of time between the end of chemoradiotherapy and surgery where we have a space to really optimize people. Ideally, throughout chemoradiotherapy, stay as active as possible. We know that it helps to minimize symptoms such as fatigue and nausea. And then during that period of time between the end of chemo and surgery, a multimodal prehabilitation program is ideal.
And what does that mean? And
Yeah.
just tell people where the esophagus is.
So the esophagus is the tube that goes from your mouth to your stomach. And it's a cancer just there. And the surgery for that is it's a big surgery. And so the risk of complications is relatively high. And so a multimodal prehabilitation includes exercise training and support from a psychologist to minimize anxiety and prepare psychologically for surgery, and also to optimize nutrition. And when we're looking at a good exercise program, the fuel is so very, very important, particularly after a period of chemotherapy where it can knock you around and the fatigue is there, and you might feel quite a bit less fit than you would have normally, and you might have lost some weight as well. So making sure that you'll have a good nutritious diet with sufficient protein, and Bernhard has commented there about timing of protein, is really important.
Could I just say, sometimes people who have head and neck cancers or esophageal cancer may not be able to swallow for periods of time if they have an impact of radiation or whatever. And you can, of course, have a nasogastric tube, or sometimes a tube is inserted through the stomach, and you get this kind of extra nutritious liquid food. Why I'm particularly mentioning it is that can be useful too for a person who's a bit frail or may have malnutrition. Liquid food can be an option. Is that correct? Or should I ask one of the geriatricians? But your thoughts on that?
Yeah. So there's lots of liquid supplements that you can buy just in Woolworths and the chemist. So Sustagen with higher protein, and they're really great to have after an exercise session. With regards to supplements via a nasogastric tube, that's very much the domain of dietitians and very specific to dietetics. But I'll throw it to my geriatrician colleagues around nutrition.
Can I come to Christina, please? Just a word on when those liquid foods may be appropriate for the older patient prior to surgery or even in recovery.
So look, I think there's a couple of points there. The first is certainly losing weight before surgery is not a good thing. There are certain types of surgery where that's the intention, just as a caveat, but as a general rule, unintentional weight loss before surgery is a risk for complications. So if you're losing weight or your appetite is not as good as it is, that's a modifiable risk factor. That's something we can do something about. Now, the sort of liquid sort of supplements that we're talking about, like Ensure and Resource, these are top-ups in between meals. They're not meant as meal replacements. And it's a really compact way of getting that protein and energy in. And so if you're someone who's really struggling, either because you've had something done to your gullet that it's hard to swallow and get enough in, or it's just that, you don't have much of an appetite and getting the energy in is hard, it's a really good way of getting a top-up, but it's best done under the supervision of a dietitian. In terms of feeding tubes and other things, it's certainly not routine. Feeding tubes, unfortunately, do carry their own risk of complications. And so those things are often because there is an issue with, the gullet or an aspect of their head or neck that is recovering, that they need that as a temporary thing. But the liquid food itself is not that the liquid is better, it's just a compact way of getting it in.
And just as a passing comment, if I may, I used to spend a lot of time bringing in home cooking or favourite fruits to my mother when she was in her hospital and including in rehab. Not necessary, of course, at Wolper Jewish Hospital with its excellent food, but sometimes having food from home is part of orientation too. I don't think I need to say that to the Jewish people who are watching this film. But just coming back to you, Carmela, do we have any questions about recovery at home or another question you'd like to bring?
One which I thought was also nice was how can one get rid of an anaesthetic quickly from the body?
Oh, well, Bernhard, Riedel, is there anything one can do to do that, or should one try to do?
No, there's not much that you as a person, individual, can do to get rid of the anesthetics. I think a lot of it's made up of your genetic makeup, the rate at which you metabolize drugs, etc. But a lot of the anesthetic agents that we use these days are very short acting, and so we often run infusions and to keep the levels at an adequate level. And so once we switch those drugs off, they get out of the system quite quickly. So drugs have become short-acting. They're not the long-acting drugs that used to hang around 10, 20 years ago.
Can I ask you while I have you, I know one of your key messages to people is that you need to know the plan for when you get home. Can you just explain what you mean by the plan and who makes it and what are the key things you should be looking at after surgery?
It depends on what disease we've got. So Julie, in terms of if you've got a cancer diagnosis, you need to get onto adjuvant therapy. That's a whole different story. In other words, adjuvant therapy is chemotherapy, radiotherapy after your cancer resection. And there needs to be a plan there as well, because you need to get on to your cancer treatment in a timely manner to have the best cancer outcome. So that's why we want to reduce complications. So that's why we want to address frailty and modifiable risk, so we can make sure your recovery is as smooth as possible, so that you stick to your plan, your cancer journey, etc. But the other plan is also just make the plan with your relatives or with those supporting you. Let's talk about having hip surgery or going home after knee surgery. Having a plan in place, having your relatives and knowing who's going to help you recovery, knowing how you're going to care for yourself at home, what your limitations are going to be, how you're going to support it, how you're going to do your meals, etc. And that's another plan that's important to think about before you go in for surgery.
Look, thank you. If I could come to Dr. Taylor Scott, one of our geriatricians, but who also works at Wolper. Obviously, hospitals like Wolper are one way of having a bit of extra care. But if you've had major surgery, the recovery can be some months, can't it? So Is there a sort of a checklist in your mind of what a person needs to be thinking about with their family if they've got family support so they're safe when they go home?
Yeah, and I think particularly for elective or planned surgery, there's certainly a lot you can do ahead of time. And I think we've sort of already talked about that. A lot is knowing and talking to your surgeon about what the recovery will look like. So if you're having a knee replacement, are you expected that you will be on a frame or a stick for some period of time? Will you have difficulty getting on and off the toilet? And having that expectation in your mind and then adapting that to how that will go at home. Because often you can put in things in advance of surgery. So if you needed rails on your stairs or in your bathroom, or you needed equipment at home, you can put that in place before your surgery so that you're ready to go home earlier, even with or without a period of rehabilitation. And Bernhard's already talked about some of the practical advice, you know, having meals prepared, ordering your online shopping, all those very practical things we do before, when you have planned surgery, you get the time to prepare for that.
And even unplanned, if you're lucky enough to have family or friend network. I mean, I'm thinking of someone close to me in my family who fell off a wall and had to have very major surgery on the shoulder area. And, you know, we were able, because of knowledge and networks and money, to be perfectly honest, money matters when it comes to speed, particularly, but you can have comfortable chairs that you can sleep sitting up in, there's all manner of aids, aren't there? That's why God created occupational therapy.
Certainly money helps, but there also are government services available, particularly if you're above 65 and qualify for aged care. So again, if you know you're having surgery and anticipate a period where you're going to need a bit more help, you can talk to your GP or your other care providers about having those approvals in place so that post-operatively you can put in that care.
Christina, Norris, I'll just come to you for a final comment, if I may. And just as you're coming, I just want to say we really should mention social workers in the hospital setting, because they can be a good social worker can achieve a whole lot of practical things because they know the systems for acquiring things like government-supported aids and so on. But is there any final message you want to say, Christina? Because our time is almost up. To our older viewers.
Look, I think it's just important to know that there is a lot of support out there, that there are many, many, many clinicians who, working as a team, can support you through that journey, preparing you in advance through the actual surgical stay in hospital and through your rehabilitation and recovery afterwards. So just know that we're out there and we're very, very definitely happy to help.
And Professor Riedel, the key messages for that conversation with the surgeon straight away, when, you know, that what do we need to absolutely make sure we talk to our surgeon about before surgery?
I think it's about understanding what your goals are, what you want to achieve with the surgery, understanding what the risks, the benefits, what the alternatives are, and whether it's absolutely what you want to achieve is going to be achieved, and what the risks are. So shared decision making. The higher the complexity, the more riskier the surgery, the more essential it is to have those discussions.
And I guess I'd sort of add in there, what state am I likely to be in for the first weeks, or even the first week or two? I know, of course, things can vary in the trenches, but at least having some sort of realistic anticipation. But look, it's just been so great to hear all your advice this evening. I want to thank Dr. Christina Norris and also Dr. Taylor Scott, our two geriatricians from Prince of Wales. I want to thank Dr. Jenny Mackney, our clinical specialist physiotherapist and researcher. I'm sorry I didn't get to hear more about your multimodal prehabilitation research, but we know that we always want a team and we want allied health to be there if we possibly can. But thank you for coming this evening through cyberspace from Newcastle, John Hunter, and thank you to Professor Bernhard Riedel for his expertise, Director of Anaesthetics, Perioperative Medicine and Pain Medicine at the marvellous Peter MacCallum Cancer Centre. I just want to thank you also for staying with us. There will be a feedback sheet if you could complete it. And this has been filmed, will be on the Wolper website. Please tell your friends about it. Our audience is smaller than normal tonight. And I think that's because people are thinking, I don't have surgery round the corner. But of course, we never know when surgery is going to come. And I think the quality of information that we've shared tonight will be of great benefit. And so if you can promote it through your own networks in any way that you can, that would be fantastic. I also want to thank Dr. Carmela Milka for being with us this evening and bringing us the questions from the audience. It was really great to have you here. Our next webinar is going to be on Wednesday, the 2nd of July. You can see on your screen, it's going to be on cancer survivorship, life after cancer. I'm about 13 years after my stage 4 cancer, so I'll listen with interest. So do put that in your diary, Wednesday, the 2nd of July, cancer survivorship, and we'll have another team of experts, an opportunity for you to ask your questions. My name is Julie McCrossin. It's been an absolute pleasure to be with you. Goodbye.